Welcome to the Explainer. Today we're diving into a bug that loves to break the rules. You know, the kind of gram-negative rod that pops up on the bench and makes you double-check everything you thought you knew.
And this is it right here. This is the moment your inner microbiologist says, wait a minute. You see the name Pseudomonas next to a negative oxidase test, and you just know, you're not dealing with your everyday organism.
The organism we're talking about is Pseudomonas luteola, and it's a true master of disguise in the lab, which, as you can imagine, can create huge problems for patient care. So let's get into it. And just so you know, this whole explainer is built on a comprehensive Gemini deep search, and all the sources are right there for you in the linked notebook.
Okay, first things first. Who is this organism? Really? Its journey through taxonomy is actually a fascinating story, and it perfectly captures how much microbiology has changed.
So, at its heart, Pseudomonas luteola is your classic environmental bug. It's a motile, gram-negative rod, a strict aerobe, and you can find it pretty much anywhere that's damp. Soil, water, you name it. It also makes this really distinctive yellow-orange pigment. But that love for moist environments? That's the key. That's a huge clue that tells you exactly where it's going to cause trouble inside a hospital.
And you can see its whole identity crisis laid out right here. I mean, at first it was called Pseudomonas luteola, basically the golden organism, because with that yellow color and a negative oxidase test, it just didn't fit the Pseudomonas mold. But then, of course, 16S RNA gene sequencing came along and showed that looks can be deceiving. Genetically, it was a Pseudomonas through and through. It's really the perfect example of the move from phenotype to genotype in modern microbiology.
Okay, so let's take that knowledge and bring it to the bench. How do we actually identify this thing in the lab? Because this is where you can really get tripped up.
So on your plates, a pretty unique biochemical fingerprint starts to take shape. That negative oxidase is, of course, the huge red flag that gets your attention. But then you add in a positive catalase, a positive for esculin hydrolysis, and you see that classic yellow, dry, wrinkled colony. Well, a very specific differential should be screaming in your head. And here it is, the #1 diagnostic trap. This organism is a dead ringer for another infamous hospital bug, Stenotrophomonas multifilia. I mean, look at them side by side. Both oxidase-negative, both can have that yellowish pigment, but here's the clincher, the one test you have to look at, lysine decarboxylase, or LDC. Pseudomonas luteola is negative, Stenotrophomonas is positive. And getting this right is absolutely critical, because when it comes to treatment, their antibiograms are worlds apart.
Now, while these bench tests get you most of the way there, you really want a modern method for a definitive ID. You know, MALDI-TOF is amazing. It's fast, it's usually spot on. But its accuracy is only as good as the database behind it. So if you get a low confidence score on an important isolate like this from a sterile site, well, that's when you turn to the gold standard, 16S rRNA gene sequencing. It's the only way to be 100% sure.
All right, so we've confidently identified this tricky bug in the lab. Now let's pivot to the bedside. What kind of damage does this thing actually do to patients? And who's the most vulnerable?
Pseudomonas luteola is, for the most part, a classic opportunist. It goes after patients who are immunocompromised. But its real specialty, where it truly shines, is infecting foreign material. We're talking central lines, prosthetic heart valves, orthopedic hardware. Any of those indwelling devices are prime real estate. And its superpower? It's a fantastic biofilm former. It creates this tough, protective slime layer on those surfaces that makes it incredibly hard to kill with antibiotics alone, which is why source control, literally getting that infected device out, is king.
And make no mistake, the infections it causes are severe. We are not talking about minor stuff here. Just look at this breakdown. We're seeing high rates of bacteremia and sepsis, life-threatening prosthetic valve endocarditis, meningitis, even peritonitis, especially for patients on continuous ambulatory peritoneal dialysis. These are the heavy hitters.
But then, just when you think you have it figured out, there's a twist. It isn't just an opportunist. There are well-documented cases of severe, invasive infections in perfectly healthy, immunocompetent people with no indwelling devices at all. And that raises a really important question, right? How is it doing that? The bottom line is this: if you isolate Pseudomonas luteola from a normally sterile site, you take it seriously. Period. No matter who the patient is.
So, this brings us to what is probably the most challenging part of the whole story. How in the world do you treat these infections? Because this, my friends, is where things get really messy. Welcome to therapeutic chaos.
This quote from the literature just says it all, doesn't it? There is no such thing as a typical antibiogram for Pseudomonas luteola. Its susceptibility is strikingly, dangerously all over the place. It's completely unpredictable.
I mean, just look at this table. It's a complete mess. You take an agent like piperacillin tazobactam. One study finds 100% resistance, another one reports it working just fine in patients. Same thing for trimethoprim sulfamethoxazole. So the take-home message here could not be clearer. Trying to guess with empiric therapy is just a roll of the dice. You absolutely have to perform antimicrobial susceptibility testing on every single isolate.
Okay, so you do the right thing, you run your AST, and then you hit another wall. There are no species-specific clinical breakpoints for this bug from major bodies like UCAST. So you've got your MICs, your minimum inhibitory concentration values, but what do they actually mean? How do you interpret them?
Now, the temptation, of course, is to just grab the breakpoints for Pseudomonas aeruginosa, but you absolutely cannot do that. It's a huge, dangerous mistake. Their resistance mechanisms are totally different. Pseudomonas luteola has this class A LUT1 beta-lactamase, whereas Pseudomonas aeruginosa is all about things like its AMP-C beta-lactamase. If you use the wrong breakpoints, you could report something as susceptible when it's actually resistant. This is the definition of a scenario where the lab needs to pick up the phone and talk to an infectious diseases specialist.
So what do? Well, we can look to some Dutch and international guidelines to give us a starting point. But every single treatment plan has to be built around the isolate-specific AST results. As you can see here, for really serious stuff like bacteremia or endocarditis, things like carbapenems and aminoglycosides are often a good bet, but only if the susceptibility data says so. And, I'm going to say it again, for any infection tied to a device, the rule is simple, and it is non-negotiable. The source has to come out.
And what about for kids? Well, the story is pretty similar. The same core principles apply. We've seen case reports where carbapenems, aminoglycosides, and even TMP-SMX have worked. But of course, the dosing has to be meticulously calculated based on age and weight. Source control is just as critical, and using drugs like fluoroquinolones needs a really careful risk versus benefit discussion.
Okay, last but definitely not least, let's talk prevention. We know this is an environmental organism, so how do we stop it from ever reaching our most vulnerable patients in the first place? It's all about targeting the reservoir.
And where is that reservoir? Well, it's the hospital itself. This bug is lurking in our water systems. Taps, showers, ice machines. It's forming biofilms in the sinks and drains. It can even find its way into contaminated medical solutions or hang out on reusable equipment if our cleaning and disinfection protocols aren't perfect.
So how do we fight back? This has to go way beyond just standard hand hygiene. The single most important, most impactful thing a hospital can do is implement a robust, multidisciplinary water management program. You have to control microbial growth in the building's plumbing. You combine that with rigorous sink and drain hygiene and absolutely flawless aseptic technique, and that is how you protect patients.
So there you have it, Pseudomonas luteola. It's really the perfect storm, isn't it? It's a master of disguise on the bench, it's a therapeutic wildcard, and it's an opportunist that's perfectly adapted to our hospital environment. It demands our constant vigilance, all the way from the lab bench to the patient's bedside. Hey, if you found this useful, please subscribe for more explainers just like this one, and we'd really love to hear your thoughts in the comments below. We'll leave you with this question to think about.